Good evening, ladies and gentlemen. It is a pleasure again to welcome you to Procure en Parle. For those who are joining us for the very first time, let me tell you that Procure is a not-for-profit organization like Canadian Cancer Society, except that we are entirely dedicated to prostate cancer. And since information is the very first remedy, Procure offers monthly webinars on various topics to learn about this disease, which affects 12 men every day in Quebec. Today, the webinar will focus on treating advanced prostate cancer with uro-oncologist Dr. Paul Torrenne from the CHU de Quebec. And thank you so much, Dr. Torrenne, for accepting our invitation tonight. We will have a presentation by our specialist, followed by a question period. And speaking of questions, thank you for those received in advance at info@procure.ca. Otherwise, you can submit them using the Q&A button at the bottom of your screen. They will be read during the question period. So before we begin, we would like to thank all of our donors from the bottom of our hearts, but also the official presenter of this webinar, Industrial Alliance, and our partners Astellas, Janssen, AstraZeneca, and Merck laboratories involved in the treatment of more advanced and aggressive prostate cancer, as well as both the Quebec and Canadian Urological Association. Procure is indeed not only a member of the Canadian Urological Association, but also recognized as I'm very sorry, as the official partner across Canada for prostate cancer and testicular cancer. That's great news in itself. So thanks to all of you for your support. And as time flies, and without any further delay, I'll now turn the floor over to you, Dr. Torrenne. You can now please share your screen. Good evening, Paul.
Good evening, and thank you, Winston, for the introduction. Thank you, Procure, and the sponsors for the opportunity to share this evening. Give me a second here, and I'll just share my screen so that you can see the presentation. I think that works. So again, good evening, everyone, and thank you for your interest. Tonight, we're going to be giving a bit of an overview of advanced prostate cancer. This is, of course, for information. This is not a medical visit, but I hope that you do walk away with a better understanding of prostate cancer, how we deal with it, how we understand it, and as well some of the newer treatments that are very exciting and are becoming more available to patients. And so this is an overview of the different topics that we'll be covering this evening. We'll be talking about grading and staging of prostate cancer. We'll give a brief overview of some of the treatment options which do exist. We'll talk about recurrences after localized treatments. And then we'll spend the rest of the evening talking about advanced prostate cancer, hormone therapy, chemotherapy, treatment for metastases, the role of genomics and genetics in the treatment of prostate cancer, and some new avenues for research. And as Winston mentioned, there'll be a time for questions at the end to address as we're able. So with that introduction, I'll just advance my slide if I can. Here we are. So Gleason scores and stages. Dr. Gleason is a pathologist who invented the staging, the grading system, for prostate cancer. And what we mean by grading system is under the microscope, does the cancer look aggressive or less aggressive? And the newest, most intuitive way to understand this is that it goes from a scale of 1 to 5, with 1 being the least aggressive and 5 being the most aggressive. And this encompasses an older scale where it went from 6 to 10, which is a bit less intuitive. And so the newer one is a bit easier to understand. The old scale goes from 6, 7, 8, 9, 10, but there's a difference between what we call 3 plus 4 and 4 plus 3 as to which is the dominant pattern. And so the right is sort of a schematic picture of what different grades of prostate cancer look like under the microscope, ranging from the things above, which are more normal, to the things below, which are the patterns 3, 4, and 5. And these two patterns combine to give a grade out of 10, which are then grouped into the scale of 1 to 5, which is makes the most sense to understand. And so this is how when we talk about grade of prostate cancer, we use these grades. They've also been given some names like low, intermediate favorable, intermediate unfavorable, high, and very high. It's a scale of 1 to 5. So that's what we mean by grade. And again, this is not the spread of the cancer. This is what it looks like under the microscope. Does it look like something bad or something less concerning? And so when we talk about staging of prostate cancer, we're talking about where it's located. Is it located in the prostate only? Is it located in other places in the body? And to investigate that, your doctor will do other imaging scans. And this depends on the situation, but some of these scans include a CAT scan, typically in the abdominal pelvic region, a bone scan, which is a nuclear medicine test to look at specifically if there's any spread of the prostate cancer to the bone. And a magnetic resonance scan, or MRI, is a scan that we can use to stage the prostate locally and also give some information about whether there's a spread to the lymph nodes nearby. So that's talking about staging as to the extent of the prostate cancer. There is a classification system for staging. This is the clinical staging of prostate cancer because we don't have all the information, but it's the information that you get from an examination of the prostate, a rectal examination, and combined with the imaging tests as well. And so there's 3 aspects, like in all cancers, of staging. T, which is the local extent of the cancer, N, which is the extent of the nodal involvement, and M, which is the extent of metastases or spread to distant regions in the body. And so the T stage, again, goes from 1 to 4 here, and 1 being something that's found incidentally, such as when we do an operation to scrape out the prostate for other reasons, not for cancerous regions, we may incidentally find that there's some cancer present. Stage 2 is something that we palpate when we do the rectal exam, that we can feel there is a suspicious nodule, which is confirmed by biopsy. 3 is something that's located in the prostate, but it's spread to the tissue, adjacent tissue. And this may involve just the adjacent tissue or the seminal vesicle, which is the duct which is attached to the prostate. And so that's a clinical stage 3. Clinical stage T4 is when we're talking about a tumor which is really very advanced and has started to invade other organs such as the rectum or the bladder, and that's certainly less common, with most cancers that we find being in the stage 2 or 1 or 2. And then we talk about the N and M staging, and so that's basically there's either lymph node metastases on imaging or there isn't, and same with metastases elsewhere. We classify this as 0 or 1 with some other finer details which are less important. But the main thing is it something that's localized in the prostate, or has it spread elsewhere? Because this will change the treatment ultimately. And so that's the importance of doing imaging tests to evaluate that. Taking both the grade and the stage together, we can put them together to make different risk groups. This is to say, what is the risk that this is going to be something that will affect you in the near future or in the farther future, depending on these different risks of it progressing, that is to say, progressing to spread elsewhere and cause problems. And so this is based on the T stage, the Gleason score, and as well as the PSA, which is a blood test, as you probably know. And so these are the different risk groups that are used to help guide treatment decisions in different instances. And you can read them there together. And again, some cancers are very low risk. And so stage 1, of course, cure is very possible. Even cancers in stage 2 and 3, where you have a localized disease, which is considered intermediate or high risk, it's still possible to cure prostate cancer in these stages, which is certainly good news. When prostate cancer is spread outside of the prostate, however, although we have very good treatment options more and more, it's not a situation where cure is possible. And so those would be the very high risk with metastases elsewhere. So after that brief overview, we'll talk about treatment options. And so treatment options obviously depend on the stage of the disease, as I mentioned. For cancer that's localized, there's basically two main categories of options, surgery and radiation. Each have their different flavors, if you will, of approaches to do this. Surgery can be done through open surgery or through robotic surgery. The objective is the same, to remove the entire prostate with the seminal vesicles, as well as the lymph nodes beside the prostate. Radiation therapy comes in different flavors. This can be done with what we call external beam radiotherapy, which is radiation which is initiated outside of the body and is aimed at the prostate and seminal vesicles, and as well sometimes the lymph nodes. This can be done also with what we call brachytherapy, the insertion of high dose radiation into the prostate, often done in a temporary manner. It can also be done with what we call localized brachytherapy, which is low dose, which is inserted into the prostate to stay there. This is combined with hormone therapy, depending on the stage and grade of the cancer, and the hormone therapy is given for a variable amount of time, anywhere from usually around 6 months, but sometimes longer and sometimes shorter. There is also options of different clinical trials, which are attempts to improve the current treatments, and this may involve surgery or radiation or other focal therapy treatments. And so, again, this is talking more about high-risk prostate cancer, where we have the same options of surgery, which includes a lymph node dissection. For higher risk prostate cancer, the options include usually longer amounts of hormone therapy, typically 18 months. And this again can use the same different modalities of radiotherapy. And in this category, clinical trials are more active if it's intermediate or high risk. So those are treatments for localized prostate cancer, a rapid overview. So what happens when prostate cancer recurs? The PSA test, as you probably know, is used to indicate your risk for prostate cancer, and it often leads to a diagnosis, and we attempt to have early diagnosis where the cure rates are better with the use of this test. It's actually perhaps even more useful after treatment, because it gives us a good index of what's happening to the success of the treatment. And so this test will be done after treatments to follow the success of treatments. It's a bit different after surgery and radiation in this regard, but it does in both instances give very helpful information to understand if the cancer is being cured. And so it's important to understand that a recurrence is not always a disaster. It's very sensitive. We have a good ability to detect recurrences with the PSA test, and we detect things often far before any spread elsewhere, often years before, in fact, any spread elsewhere. We have information from this test over time as to how the cancer is progressing, because if your PSA test becomes detectable, for instance, after surgery, we often will follow it for a little bit to understand, is it something that's rapidly rising, hence more concerning, or is it something that's rising very slowly? And that's done in a similar manner after radiotherapy. And the difference is surgery, usually we expect your PSA to go down to 0. After radiotherapy, it takes longer, the hormones bring it down, and we have to wait for the effect of the hormones to wear off to accurately assess it. So it takes effectively longer to assess the treatment after radiotherapy. There are treatments for recurrences. This obviously depends on your particular context. It depends on the initial therapy that you had, whether it was radiotherapy or brachytherapy or surgery. But there is the option of salvage radiotherapy, particularly after surgery. In some instances, more radiotherapy can be given. Hormone therapy, which is therapy to decrease testosterone, is also a salvage treatment option. And so when we talk about advanced prostate cancer, we're talking about cancer that's either at the outset outside of the prostate, or cancer which has recurred despite local therapy. And in this context, it's important to understand that this represents the minority of patients. Patients who present with disease outside of the prostate overall represents perhaps about 10% of patients. The survival is still good. It's not a death sentence. There is many years which can be lived well with advanced prostate cancer in many patients. Obviously, there's a large variety of presentations, and then there certainly has been a very significant improvement in the last decade in terms of outcomes and available treatments that we can offer. There is obviously some issues with bone health in this context, which we'll talk about as well. So for cancer that's spread outside of the prostate, your treatment obviously depends on your particular context. Treating someone who is 95 years old is done differently than someone who is 65, as you might imagine.
Excuse me, Dr. Torin?
Yes?
I'm sorry, I will be just taking a moment of everybody's time to say that we're very sorry, but the interpretation seems to be an issue at the moment. So for anybody that would like to listen to this webinar in French, the translation will be available on our YouTube page as soon as possible. So you will be able to get the link, as you usually do, by email in the next couple of days, just to be able to listen to this webinar in French. I'm just going to repeat that in French very quickly, and then I'll give you back the floor, Dr. Torin. Donc, bonsoir à tous. Malheureusement, nous éprouvons des problèmes techniques présentement pour l'interprétation en français. Nous nous en excusons. Si jamais vous avez besoin d'écouter ce webinaire en français, sachez qu'il sera disponible dans les prochains jours en français, en rediffusé. Donc, n'hésitez pas à ce moment-là à écouter le webinaire en français. Nous allons vous envoyer un lien lorsque celui-ci sera prêt. Merci beaucoup, Dr. Torin. I'll give you back the floor to you. Thank you.
Pas de problème, merci. And so when talking about selecting the appropriate treatment for metastatic prostate cancer, the stage and grade of prostate cancer, as well as your PSA level, are taken into consideration, as well as the existence of other comorbid, as we say, diseases, other medical problems that you may have, as well as the extent of symptoms you may or may not have. And so this gives a bit of a list of some of the options which exist currently for metastatic or prostate cancer, which is spread to other regions of the body, such as the bones. We have standard hormone therapy, which is essentially treatment that takes away the testosterone. Testosterone is like the fuel for prostate cancer. When we give treatment to reduce testosterone, it very effectively, in fact, slows down prostate cancer. There's what we call next generation hormone therapy, which acts in essentially the same way, except it's much stronger, and it blocks the actions of androgens and testosterone such that the cancer effectively regresses. These are treatments that work very well, but they're not treatments that eliminate the cancer. The cancer does ultimately persist and recur at some point, but the response can be excellent. And so these are both standard and what we call next generation hormone therapy. We do use radiotherapy for cancer which is spread outside the prostate, whether it's radiotherapy to the prostate or radiotherapy to the metastases, particularly in painful regions such as the bone. And this can help alleviate symptoms and provide quality of life. Chemotherapy is used in certain circumstances, depending on the progression of the cancer. It's not the mainstay. The mainstay is really hormone therapy, but we do use chemotherapy as well. There are many interesting clinical trials. These are treatments that have shown promise in other contexts, and then we of course need to do the clinical trial, one to show that it works in some instances, and in other instances we need to do the clinical trial to prove to the government to have approval, despite it being shown effective in other countries in similar situations. Surgery to relieve symptoms can be done for certain problems, and we treat bone metastases sometimes with radiotherapy, more rarely with surgery, and there are medications which can protect the bones to avoid having problems related to metastases. So the role of hormone therapy, as I mentioned, this works by stopping the production of male hormones, particularly testosterone, and slowing the growth and spread of prostate cancer. And this response can be very good, lasting from months to years, depending on the cancer. And it's a mainstay of treatment for advanced prostate cancer. In the presence of recurrent prostate cancer, it's the same treatment, hormone therapy. This is usually given with a series of injections that are given every 1 to 6 months, depending on the formulation. And it's the same treatment that's given at the outset with radiotherapy, and it can be used in this context for advanced prostate cancer as well. So as I mentioned, hormone therapy will not cure prostate cancer, but it is effective for the following aspects. One is it's a systemic treatment. It reduces testosterone throughout the body. So whether the cancer is in the prostate, whether it's in the bones, we do see a response at all sites. And so it can actually reduce the size of tumors. It can also, as I mentioned, increase the effectiveness of radiotherapy. And that's why it's given at the same time, whether it's 6 months or whether it's 18 months or somewhere in between. And it can effectively suppress the growth of prostate cancer, which has recurred, for instance, after either radiation or surgery. And so it's really a mainstay for treatment of advanced prostate cancer. There are different ways to do this. As I mentioned, the injections are given at different frequencies. There's what we call next generation hormone therapy. These are different pills we'll mention in a couple of slides that are given orally and have been available in the last 5 or so years, 5 to 10 years. And there's also surgery, we call a simple orchiectomy, where we actually remove the testicles because those are the organs which produce testosterone. And this effectively gives a very same result because there's no testosterone produced, and it can avoid having the recurrent injections, but it's a small surgery nonetheless. And so the medications that we give by injection are called LHRH analogs. That is to say, they resemble a natural protein which is produced in the body, and the dose that they're given in results in a suppression of testosterone. These are the leuprolide, glycerolin, and triptolurolin. There's something we call...
Allô, that's good. Oui.
Do you hear me now?
Yes, no problem.
Okay, sorry. We're talking about antagonists. These work in a slightly different way, but have the same ultimate effect of suppressing testosterone. And then there are oral pills such as bicalutamide, which are the older anti-androgens. So I mentioned the different ways of giving it, typically 3, 4, 6 months. Casodex tablet is given at the outset of the LHRH agonists, usually for a month, and then we'll follow the PSA test to see the response rates. So PSA tests, as I mentioned, are a measure of essentially globally what's happening with the prostate cancer. And so we can measure these serially following hormone therapy to see how the cancer is responding. If it goes very low, that's a good sign and showing that the cancer is responding very well. When it starts to rise, despite the hormone therapy, that's an indication that the cancer is becoming resistant. And at this point, particularly more imaging tests or treatment will be considered. And so increased PSA during hormone therapy, what do you need to know? This doesn't typically happen right away, but it can happen over time. The longer and the lower the PSA goes, the better the response and the prognosis related to that. If it does rise, it depends obviously the rate that it rises. And we want to make sure that the medication to suppress the testosterone is in fact low as it should be. If it increases faster, then it's obviously more concerning. And it's at that point we can add next generation hormone therapy. And so these are the approved molecules: enzalutamide, abiraterone, apalutamide, and darolutamide have all been approved for slightly different and similar contexts with metastatic prostate cancer at the outset. being the most recent and important use of these medications. It's also, as I mentioned, used for cancer which has become resistant, whether or not you have metastases, and it can be used for recurrent prostate cancer, which again has metastases associated. And so this blocks the action of testosterone. There are medications which are given orally. They're fairly well tolerated, and they do delay progression of the cancer, delay the spread to other bones, and they do significantly extend survival or the onset of the chemotherapy. Chemotherapy is typically used after these medications when these medications ultimately fail to continue to give a benefit. Chemotherapy can have the same effect in slowing the cancer, increasing survival and quality of life. And these are systemic treatments, that is to say, they treat the cancer wherever it is in the body. And this can also help control symptoms, which can be related to the spread of cancer in its advanced stages. There are two types of chemotherapy which are approved in Quebec, docetaxel or Taxotere and cabazitaxel or Jevtana. And these are chemotherapies with side effects like nausea, vomiting, and hair loss, and so on. These are given in cancer centers, and they're often given with a steroid called prednisone, which makes it more tolerable, and typically given every 3 weeks for anywhere from 6 to 10 cycles. Each treatment takes about half an hour to receive. But the duration obviously can be adjusted by your oncologist according to your context. As I mentioned, these do have the side effects of chemotherapy, particularly nausea, vomiting, fatigue. There's a susceptibility to infections, which is associated with the immunosuppression and some nail changes. And so it's important to be followed by physicians experienced in giving this. Word about bone metastases. And so there are medications which help prevent deterioration in the bones, which come with hormone therapy. The one that's most commonly used now is denosumab or Xgeva. Zometa or zoledonic acid has also been Health Canada approved. Xgeva is usually given as a monthly injection. In Quebec, we give this every month typically. And it does strengthen the bones, decrease bone-related complications, including pain, and help maintain quality of life. And so depending on the exact context, it can be a very good option for you or your family member. As I mentioned, the radiotherapy can be given to help palliate bone metastases which cause pain. And this can be given in 1 day or sometimes in a couple of treatments. And it does help significantly to relieve pain and palliate any symptoms. Radium-223 is a radioactive nuclear medicine element, which is essentially injected in the bloodstream, and it has a propensity to go to bone metastases. And the radiation that it emits essentially helps shrink and control the bone metastases, resulting in an improvement in pain for patients who have pain, since this medication is only given to those patients. And it's for something that does also improve quality of life as well as survival. And but it's only given to patients who have painful bone metastases, but it is approved for use throughout Quebec. Genetic testing for prostate cancer. This is a new topic that's come about in the last few years. We found that certain mutations, we'll get into briefly, are related to the progression of prostate cancer, and there are some treatments specifically available. This is not an exhaustive list here, but certain patients are more at risk of having the genetic mutations. There's a very strong history of multiple cancers, particularly related to the BRCA1 genes you might have heard of, like ovarian, pancreatic, prostate cancer. Those of Ashkenazi Jews are known to have a high prevalence of this mutation, as well as others who have known hereditary cancer syndromes. There are certain patients with very high-risk prostate cancer where the recommendations are starting to emerge to recommend testing for these groups, but this is an evolving thing, certainly new in the last 2 years. The mutations that we know about prostate cancer is certainly in evolution. 2 key genes are BRCA1 and BRCA2, which are known to be involved in breast cancer and ovarian cancer, but they also have a role in prostate cancer. There's something called the Lynch syndrome, which is another set of genes which are also related to prostate cancer, and some other genes which the jury is still out on the exact importance, but certainly may be important. So the importance of this genetic testing is that for patients with advanced prostate cancer, there's a treatment we call PARP inhibitors, which is targeted for patients who have that mutation, particularly in Quebec. It's approved for BRCA1 and 2. And this is an interesting treatment option that's Health Canada approved if you have the mutation. There is some implications for family members when we have this test, because if you find out that you do have the mutation, there's consequences for your family who may also be at risk to have cancer related to this mutation. And so there's a genetic counseling that's recommended for all people who have this mutation to understand the consequences for family testing. So advancing rapidly, what are some other research advances and other things coming down the pipeline? This is a fairly busy slide, but it explains where we're at in 2022 regarding treatment of what we call advanced prostate cancer. We divide this into sort of 2 main categories: hormone-sensitive prostate cancer, that is to say that it responds to hormone therapy, and castrate-resistant, which means to say that patients who have castration, who are castrated, their testosterone levels are undetectable, but nonetheless, the cancer becomes resistant and progresses, often indicated by rising PSA, but also by the imaging tests which are done. And then we divide that further into 2 main categories: whether it's metastatic, it's spread elsewhere, or whether it's non-metastatic, that is to say it's localized only in the region of the prostate or the prostate. And the treatment options have evolved. For patients who are metastatic, it's very clear now that hormone therapy alone is not optimal. Obviously, in some context, that's all that's feasible. But for patients who can have combination therapy, we now recommend having hormone therapy with another treatment. And there's the 3 that are listed there on the bottom left: enzalutamide, apalutamide, and abiraterone. More recently, abiraterone given in combination with the docetaxel, or docetaxel more recently with darolutamide, are options for patients who have what we call hormone-sensitive metastatic prostate cancer. For patients who have cancer that's resistant but not metastatic, there are 3 molecules, enzalutamide, apalutamide, and darolutamide, all supported by large phase 3 trials, which are effective to slow the cancer before it spreads. And these are relatively well-tolerated medications. And it's clear that adding these in combination with hormone therapy is very helpful. When we get to the bottom right, the category of patients who have castrate-resistant metastatic prostate cancer, there's even more options. There's all the options of using enzalutamide or abiraterone, which are the approved agents targeting the androgen pathway. There's the option of different chemotherapies we mentioned earlier, whether it's docetaxel or cabazitaxel. There's the option of radium 223, we mentioned particularly with patients who have painful bone metastases. Olaparib is what we call the PARP inhibitor, the medication that's specific for patients who have a mutation in genes related to DNA repair, such as BRCA1 and 2. And we'll talk about in a slide or 2 about lutetium PSMA, which is a radioactive molecule given by injection, which specifically targets prostate cancer wherever it is in the body. And as noted on the slide here, all these agents in these categories are given with the foundation, if you will, of ADT or androgen deprivation therapy, hormone therapy, which we're talking about. So hormone therapy is given for all patients who are receiving what we call systemic or treatment that treats the cancer wherever it is. And so this does involve many considerations. the context changes over time. Not all patients remain hormone sensitive forever, and eventually the cancer does evolve to become hormone resistant. Not all cancers stay localized forever, and some of them will, not all of them, but some of them will then spread elsewhere. And so this different staging as we review things in clinic is involved in our decision making as to when to change treatments and when to move on. And certainly doing imaging helps assess things, and this is why we have follow-up visits with blood tests and different imaging tests, as well as assessing symptoms. We obviously want to move to improve our treatments always, and research is a big part of that. Genomic research is one area of research which has been quite busy over the last 10, 15 years. And identifying different genomic features which are important to cause cancers to become resistant and so on. And there's different genes here for the scientists that are listed that may have a role in helping prostate cancer evade the current treatments. PSMA PET is a new imaging test which is based on PSMA, which is a molecule on the membrane or the surface of certain prostate cancers. And it helps us with the combination of a PET scan to see cancer in a way that we couldn't before. It's a very sensitive test, and it can help us identify metastases easier. There are a lot of nuances to using it, however, and it's not yet approved in Canada. Currently, it's available through clinical trials because it's not yet approved. But it certainly has a role that's upcoming and remains to be fully defined, but it's a very useful test. It's particularly useful in the context of lutetium, where this is the test that you need to have in order to have lutetium as a treatment option. Lutetium is not a Health Canada approved option, but it is certainly has evidence that it works in many other studies in Australia particularly. And so it is available at our center and many others through clinical trials as an interesting option for certain patients. So it's important to understand that things have really evolved a lot. It's wonderful to see that research is starting to pay off, particularly in the last decade. Of all the treatments that I mentioned, about 3/4 of them have come out in the last 10 years. And they are more and more effective. This is improving the outcomes, survival, and quality of life for our patients with advanced prostate cancer. And it's important that we continue the research and advances to make this better. And so I would, as a researcher myself, put a plug that it's important that we invest in research. We are at the forefront of it in Quebec, and we appreciate very much the support of Procure in this regard as well. So with that, I will stop a bit early and certainly take any questions. And thank you again.
Hello, Paul. I have some questions here. The first one would be, what is the percentage of recurrence after surgery or radiotherapy, with or without hormone therapy? And can we know where that recurrence is?
Sure. So recurrence, again, is almost always detected by the Psa Test. The success of the different treatments, comparing radiation and surgery, as I say to my patients who I see in clinic, it's difficult. It's difficult for several reasons. In surgery, when we are assessing outcomes, we're assessing outcomes based on the entire prostate, which has been removed with the lymph nodes. And so we have what we call pathological staging. In radiotherapy, it's based on the biopsies and the clinical staging beforehand. There's also the problem of defining a recurrence after treatment is not the same for radiation as for surgery, in the sense that the PSA levels are somewhat arbitrarily defined for both treatments, which consider recurrence. It's also difficult to compare the two outcomes because it's not the same patients who have the same treatments. In general, patients who are younger and healthier are better suited for surgery, and patients with more comorbid problems are often more having radiotherapy. So it's difficult to compare the two. What I tell patients in clinic is that globally, the treatment efficacy of the two options are very similar. If we look at numbers, again, it depends on who you treat. If you're treating patients who we would now put on active surveillance, for instance, then your outcomes are very good, but you shouldn't always be doing that. So, but globally, a number that most people sort of hang around with is in the ballpark of maybe 25 to 35%. But some series have been higher, some series have been lower. But I think globally, the results are similar for radiation surgery in this regard. The difference is that surgery, we understand the recurrence is much earlier because it's a lot easier. Your PSA should be 0. And if it's not 0, it's a lot easier to see that. Whereas it takes longer after the hormone therapy, after radiation, to do that. And that's why if you look at comparing radiation and surgery, although the results are similar, when you try to adjust for the different factors that are different, there always is a slight tendency to have perhaps better long-term oncologic outcomes with surgery. But again, these are not statistically significant, and it's probably related to the fact that it slightly tends toward surgery because we identified the recurrences earlier and the option of radiotherapy remains after. But as a global number, it's probably, again, depends on who you treat, and but it's in the ballpark of 30% or so, most people would say.
Okay, thank you. Second question, if hormone therapy is prescribed, how long is the usual treatment? And do specialists continue to prescribe hormone therapy for life?
So there's two main categories, as we sort of went through fairly quickly in the talk, that we use hormone therapy. The first is with radiation, and this is for a defined period of time, whether it's 6 months, whether it's 18 months, and then it's stopped. And there's no intention at the beginning to continue it longer or to give it afterwards. The other main category is in the category of patients with recurrent disease or patients who have metastases. And in patients who have metastases, in general, with very few exceptions, once we start it, we continue it for life. And the reason is that when we stop it, the testosterone comes back and we'll start to feel the cancer.
Right. When we have metastases, can the treatments make them disappear?
Fortunately, yes, you can have a response where the metastases do disappear. And certainly with hormone therapy in combination with our newer molecules, we're seeing this not infrequently. And patients with cancer everywhere in multiple places do see very significant responses. Some of the treatments we mentioned, lutetium is one of them, and olaparib, these other treatments as well do work. And we see patients who have cancer, despite it being resistant, seeing regression or disappearance of metastases. But again, it doesn't happen in every case. But can these treatments have that effect? The answer is certainly yes. And so they're good options, and it's good to have good options.
Okay, thanks. This patient says my urologist prescribed apalutamide. Maybe I don't pronounce it right, but I would like to know why I always have to have my standard hormone therapy injections if I am resistant to this type of hormone therapy.
Sure, that's a good question, and one that I've heard more than once. Essentially, there's two main reasons why we continue the hormone therapy for life, despite, as I said, the cancer becoming resistant to it. The first is that if we give it back, it will probably make the cancer more aggressive. And so it doesn't make sense to take away a treatment, even if it is providing the cancer is resistant, it's only partially resistant. And so if we take it away, the treatment will probably advance more. The other reason is that all the studies that were done continue it after. So even though the cancer is resistant, in all the studies that have been done in every situation, we continue that treatment when we add the next ones. And so in virtually all instances, we will continue it. There's a few exceptions where we do sometimes start and stop it, particularly with recurrent cancer that's not metastatic. We can do what we call intermittent therapy, where we'll start it, we'll stop it, we'll start it until things progress more or there's some metastases which develop.
Okay. At this time, I would just like to repeat that we had some difficulties, mesdames et messieurs, nous avons eu quelques difficultés. Nous nous en excusons, c'est-à-dire ne pas pouvoir fournir l'interprétation simultanée en français pour ce soir. mais ne vous inquiétez pas, vous aurez accès à la version doublée en français sur la page YouTube de Procure. Okay, so Dr. Torrent, we'll continue with the questions. This gentleman is aware that there are two new treatments that have been approved for aggressive prostate cancer. Olaparib is one of them. What is it, and who can have this treatment?
Right, so olaparib was recently approved by Health Canada and has more recently been approved by the Quebec government so that we're able to have it funded. This is a medication which works on tumors or patients who have a mutation in BRCA1 or 2, which are genes which are involved in DNA repair. And so it basically takes advantage of the problems that are incurred with this mutation to kill the tumors as a result. And so having this gene and then taking the drug is sort of like a double hit where you're able to then kill the cancer in a very selective way. This is a therapy that's used for other cancers and has now been approved for use in prostate cancer. It's an oral therapy, a pill that you take. It does have side effects, but in general, it's much more tolerable than chemotherapy.
Right, double whammy sort of thing. My urologist, next question, told me about a new lutetium treatment, but cannot guarantee if I'm a candidate for this innovative treatment. What is it exactly?
Sure. So this is a radioactive molecule, which is given by injection. It's given by the nuclear medicine physicians. And it's designed so that it attacks a specific molecule on the surface of prostate cancer called PSMA. And when the molecule arrives, it attaches to the surface, and it's piggybacked on the molecule is a radioactive isotope called lutetium. And this radioactive isotope emits radiation, which then kills the cell to which it's attached. So it's a tailor designed treatment, which has been proven to be very effective. It's not available throughout Canada, as in it's only available if you have a clinical study. Certainly, I know there are clinical studies open in most, if not all, the 4 academic sites in Quebec. And this is a very interesting treatment option, which has proven efficacy in large trials elsewhere. But
Go ahead.
But it's only for patients with advanced prostate cancer. You need to have resistant prostate cancer.
Dr. Doran, what would you say about the evolution of the research and how we've come around to being able to treat better and better this prostate cancer as such compared to 25 years ago? How long can men survive with advanced prostate cancer?
Right. So advanced prostate cancer, that is to say, patients with cancer spread outside the prostate. The only treatment that was been around 25 years ago was hormone therapy. And now, as you saw, we have almost 10 different treatments. And the prognosis 20 years ago, when it became resistant, was less than 2 years. Now it's easily past 5 years or more. And so certainly that's a big improvement. And there's many more improvements on the horizon with more and more treatment options coming through clinical trials. So it's a lot better. We still have a lot of work to do, but it's encouraging to see real substantial progress.
Right. If and a sub question would be, how many types of cancer have we identified over the past 25 years? I mean, how many did we know then, and what has it become since?
Well, the incidence of metastatic prostate cancer has actually decreased with the advent of PSA screening, which started in the 1990s. And as a result, we picked up a lot more cancers before they had spread elsewhere, at which point the cure rates are a lot better. And so we have decreased the incidence through screening, PSA screening, of advanced metastatic prostate cancer. But there still remains a large number that occurs. This is a very common cancer in men. And so there's more work to be done.
And it's expensive. The research is expensive, right? So that's why we need people to come to Procure and right along. Like we have an event. I don't know when this will be heard or looked at, but we have an event which is La Marche du Courage Jean Pagé, which is a very good source of funding. And we also have l'affaire Papillon in the fall, that is another good source. So how much would you say is needed on an annual basis for research to keep progressing? Are those numbers available?
I'm not sure I'd be the best one for those numbers, but I can tell you that running clinical trials, because we do a lot of that in Quebec, is very expensive. There's a trial with lutetium, for example, that was funded by different philanthropic organizations in Canada. And this trial costs millions of dollars to run. This will prove that lutetium, for example, is effective in CRPC, and we can have approval in Canada as a result, we hope. But these trials cost millions of dollars to run. It's not cheap.
In Quebec, we have like 4 hospitals, one in Sherbrooke, there's a couple in Montreal, one in Quebec City. Is this like across Canada? Are they doing the same type of exercise research-wise?
Yes, I mean, there are major research centers across Canada. Certainly Montreal and Quebec, we're very involved with the prostate cancer research community. Sherbrooke is involved as well to some extent, but we're at the forefront of it. Our center in Quebec, for instance, was the first in Canada to offer lutetium through various trials that we've been involved with now for almost 5 years. And this is a real advantage for our patients. And a lot of the support that we get from this comes from fundraising activities to help support our research team. And it's similar in Montreal as well, I imagine.
What about Ontario, Toronto, out west and in the Maritimes? Is similar research happening too?
Yes and no. I mean, some centers are more active than others. Certainly Toronto and Vancouver have very active. It's a big city, a lot of research there, but other centers as well, Halifax and Hamilton and London and Alberta as well. So I think it's variable. I would say that in Quebec, we're very active. I'm a clinician scientist, and there's actually 4 of us who are clinician scientists. As to say, we spend almost 50% of our time doing research to help improve outcomes. And so we're active in this,
Right. And what's the perspective? I mean, if we look at it like in 10 years from now, how much do you think we'll have moved forward in research and that type of study?
Well, it's always a difficult question to answer specifically, but I could at least say that in the last 10 years, there's been very concrete, significant improvements through research that is coming to fruition. I think our goal in the next 10 years is really to develop more precision medicine for prostate cancer patients. This is a reality in other cancers like breast cancer, but it's only just starting to be, for instance, the genomic testing I mentioned. I mean, prostate cancer was unfortunately one of the last ones to sort of get into this field. And so there's definitely more room for more personalized treatments, and that takes research to do so.
Well, thank you, Dr. Torn. We're coming to the end of this webinar, so I'm speaking to, I'll put my imagery back on. Here we go. We're nearing the completion of this webinar, and your opinion matters to us. The people that are out there listening, your opinion matters. So please fill in. There's a quick survey that you can take. It'll appear on your screen. Outstanding questions will be answered individually, of course. And also, I would like this to specify that this webinar was made available by one of our major sponsors, Bayer. Thank you very much, people at Bayer. So once again, a huge thank you, Paul Torn, for your expertise and your precious time. It's extremely appreciated. So our next rendezvous will be in September. And as usual, we will be holding a special series of 4 webinars as part of the Prostate Cancer Awareness Month starting on September 8th, knowing that September is the month of awareness for prostate cancer. Same place, same time. So stay tuned and do not hesitate to call us if you have questions. We're there for you 7 days a week. You can get in touch with us very easily, procure.ca. And thank you, and summer included, of course. I mean, we're there like 24/7, 12 months a year. Thank you, everyone, and have yourself a great summer. Thank you again, Paul. Have a great summer. Bye-bye.